Bismillahirrahmanirrahim. Good morning. Today we have gathered to have a discussion on the management of urethral stricture. So Dr. Numan will be presenting it.
Assalamu alaikum. Auzubillahi minash shaitanir rajim. This is the continuity of our series of urethral stricture lectures, and today is just a brief review of previous lecture, and then we will going to see the management options for urethral strictures. And our objective here today is to understand about the urethral dilatation, DVIU, and non-transaction urethroplasty. We have already gone through the urethral stricture definition, etiology, and causes. And there are some. It is a fixed anatomical narrowing of the urethra so that the lumen will not accommodate the instrumentation without disruption of urethral mucosa lining. You can appreciate the stricture in retrograde ureterogram in this picture and in second endoscopic view of two types of stricture. Narrow segment in the anterior urethra due to the process of spongiofibrosis and cicatrization of the urethral mucosa surrounding spongious tissue. In male posterior urethra, there is no spongious tissue and at the location, so the term is stenosis is preferred in there in posterior urethral part. And in female urethra, the fixed anatomical narrowing it is an alternative term for the urethral stricture. What is reduced urethral calibration? It is defined as the less than 14 FR caliber of the urethra. Means that you cannot pass 14 FR or more than 14 FR catheter through the urethra with an ease.
I think it is important to understand to differentiate between the urethral stricture and the urethral stenosis. Or when there is spongy fibrosis in the anterior urethra, it is called as urethral stricture. When it more or less same pathology lies in the posterior part where there is no spongy fibrosis, there is no corpus spongiosum, it is called as stenosis. The management also depends on this.
The pathogenesis is the stricture are the consequence of epithelial damage and spongiofibrosis. It is basically the body's immune mechanism towards any injury inflammation. Whenever there is an inflammation to any etiology like noxious stimulus, UTI from the chemical damage or physical disruption of the continuity of urethral mucosa or squamous metaplasia, or there is a fissure in the epithelium or extravasation of urine into the corpus spongiosum after the fracture or fissure or fibrotic plaques which they join each other and cause the damage to the structure. And whenever there is such inflammation, injury, etiology, the natural response of human body to heal, it always heals with fibrosis, and that fibrosis leads to a stricture in the anterior urethra and stenosis in the posterior urethra and the female urethra. This is just the brief review of erythrogram, and we will not going to bother it for long. But on the in this picture, the post-traumatic bulbar urethral stricture, you can see the whole penile urethra. It is normal, and when there is a U-shaped bulb, this is a bulbar urethra. Pinobulbar, this is the stricture from where you can the dye is passing, but with the narrow caliber, very narrow caliber. And this is a complete blockage of bulbar urethra, and in this the arrow is showing minimal opening or pinpoint opening showing on the retrograde ureterogram. And this is another just picture post-inflammatory penile urethral stricture. You can see from here to this end, the whole it is a pan penile urethra system. The whole penile urethra is stenosed or termed as the penile urethral stricture, and the complete urethral disruption. And you will appreciate the new term pelvic fracture urethral injury or PFUDD. And this is the ischium is broken here in this AP view, and in the retrograde ureterogram dye it is extravasating in the penile and bulbar urethra.
So the term urethral destruction is used for the posterior urethra.
And this is the ureterogram of a patient which is showing when they pass the dye retrogradely, and the contrast from the bulbar urethra it is also entering in the rectum. And in this picture, it is elaborately showing that there is a fistula between the rectum and the posterior urethra. This is a bladder, and contrast is opacifying the rectum, and it is going upward. It is also bulbar stricture and it is an MCUT in widening film anti. When to plan or how to plan for the urethral strictures, the surgeon has to identify the cause of strictures. If it is UTI, the management might be delayed or stage or different. The site of stricture is also it also decides for the managing option like anterior urethra or posterior urethra. They might differ. You should do the DVIU or dilatation or urethroplasty. These three things they differ according to the location of the stricture and how much the length of the stricture is there, and either it is completely obliterating the lumen or it is incompletely obliterating the lumen, and depth and density of spongy fibrosis which we can appreciate on ultrasonography of whole penis and urethra or peroperatively. And there are some secondary complication of the stricture like the urine stress in the bladder. It can cause vesical calculus formation, and in some most of the patient when they are chronically straining voiding with straining, but the urine is accumulating in the bladder, they might affect the upper tract and they might lead into the renal failure. And it can also be associated with some other pathologies which are also associated for causing the low urine tract symptoms. What are the temporary measure and definitive measure? Whenever there is stricture, as it is our classic teaching in SIUT, whenever you have the difficulty in passing the Foley's catheter in a patient with retention or with difficulty in micturition, don't force it and pass the suprapubic catheter, so that the whole etiology and the anatomical pathology of stricture, it lies actually. No, we don't have to disrupt the urethral mucosa by forceful entering into the mucosa and to the bladder. And what are the definitive treatments? Definitive treatment, you have to remove or you have to combat with the stricture. You might deal with dilatation under vision and then sequential dilatation. You do the endoscopic internal urethrotomy, and there are some urethral stents. You can apply them on the stricture part, and the definitive is urethroplasty. What are the indication of temporary treatments? Patient came to you with the retention, or when patient came to you with the continuous leakage of urine from the penile shaft or the scrotum or the perineum, or there is uremic symptom in the patient, which is the complication of the stricture urethra. At that time, first you have to divert the urine, and the temporary measurement is suprapubic catheterization. Or the patient is unfit for surgery due to the bleeding, diathesis, or old age, or other conditions like in which he is not bearing the pain or not optimized for surgery or anesthesia. Or the third and the most important, if you lack the expertise and you don't have any experience, so for the stricture urethroplasty or the endourological procedure, you do the temporary measure and refer the patient to the specialized center. Urethral dilatation, it is the primary or first thing it is to need to be learned for the urethral stricture. You dilate the urethra, recalibrate the urethral lumen, ideally maintaining the integrity of mucosa and reducing the risk of scar tissue formation. The goal of dilatation is that you dilate the urethra without disrupting the stricture or without disrupting the urethral mucosa. Because once you dilate the stricture, you stretch the stricture, and you stretch the stricture to the point that no, while dilating the urethra, there is not enough force. You will feel the force applying to by passing each dilator inside the lumen. And when the force is more, the stricture might disrupt and it may cause increase in spongiofibrosis beyond the original stricture part. And if bleeding occurs during the dilatation, it means that you have gone through the stricture part and there is more stretch over the urethra, and the actual pathology site is increased from 1.5 centimeter. It might increase in depth or it might increase in length.
Ideally in urethral dilatation, there should be no bleeding at all. If while during urethral calibration or DVIU, when you encounter the bleeding, it means you have gone beyond the limit or beyond the boundary. So unfortunately, this is in a bad uh, pos- uh, I would say this is not in a good position for the patient. You have actually advanced the urethral stricture disease. So ideally, there should be no bleeding while you are doing urethral dilatation or DVI.
And the dilatation can also be used an associated or consolidating method after DVIU. When you do the DVIU, you have ruptured the urethral ring, stricture ring, and you do the dilatation sequentially in the follow-up so that the stricture cannot reoccur on the same side in the near future. The potential curative treatment for well-selected patient like less than 2 centimeter incomplete epithelial stricture with no spongiofibrosis, and the frequency of dilatation it increasing interval for initially after the first dilatation, the second dilatation is in 2 weeks, and then 1 month and 3 months and 6 months, and continued indefinitely. Once there is a stricture, it will remain there no matter what. What are the instruments we use for the dilatation? We use the catheters, we use the bogies, which are made of the plastic or metal, uh, and the balloon catheters, like balloon dilatation of urethral stricture. And there is a hydraulic self dilatation by initiating the micturition desire and holding the glass penis in your hand or meatus and then forcefully trying to micturate. It is a hydraulic self dilatation. The urine will come with a force and it will disrupt the stricture. And there will be sheer pain for a moment there. What are the flexible boogies? These are the we have seen both of these with the cone like end with it is open, more blunt and dangerous ends, and you can use these malleable or flexible bogies for the stricture dilatation over the glide wire. The purpose of this cone is that you pass through the stricture easily without disrupting or without tearing away the urethra. When the force is more than, and you think that I am applying more force and it is stretching the whole urethra more than my own requirement or more than the patient own anatomical lumen, you should stop there. Whenever there is a bleeding during the dilatation, this means that you have advanced the disease and gave the temporary measure to the patient. And these are the curved. We have seen also these of with multiple and different numbers of from 5 7 FR till 24 FR. There are limited indications for urethral dilatation located in the immediate vicinity of a striated sphincter, like in the pinobulbar or bulbomembranous junction near, and post-prostatectomy stenosis of the vesicourethral anastomosis. And you have to dilate that because in the prostatectomy, radical prostatectomy, you remove all the capsule and directly anastomose the bladder neck to the urethra. There are high chances of bladder neck stenosis, and you have to dilate it. And prevention of stricture recurrence after DVIU or initial urethroplasty. These are the indication of continuous, frequent, sequential dilatation. What are the complications of the urethral dilatation? When you do the dilatation and there's the bleeding and you do dilatation retrogradely, the blood might accumulate in the bladder and patient might went into the clot retention. The urethral rupture might be there. The patient may have the infection, prostatitis, cystitis, epididyma, or orchitis, pyelonephritis, bacteremia, or prostate might get rupture, which may cause bleeding and clot retention, simple mucosal abrasion, or urethral false passage or perforations of the bladder. There are multiple studies done in the West or in our South India, which are showing that the immediate success rates, the patent lumen is near from 59 to 100%, and a majority of the cases they require the re-dilatation after the variable period of time from 3 days to 12 months. And the second option is DVIU, endoscopic direct vision internal urethrotomy, is another procedure which opens the stricture by incising through the scar transurethral to release the contraction to allow the lumen to heal and enlarge. It was introduced first by 1974 by Sachez, the person uh, who has the label on the instrument of Sachez knife, Sachez cold knife. The urethra is then splinted with an indwelling catheter for 2 to 7 days or 14 to 21 days for difficult stricture, so that the urethrotomy part it remains away and the healing is by the primary from the ends, and it is a healthy healing. It is the first line therapy for the short stricture less than 1.5 centimeter and the caliber more than 15 F French in caliber in the absence of dense or deep spongiofibrosis. And the friction free rate is 50 to 70% post DVIU. The instrument we use are sachets, urethrotom, electrosurgical devices, and the lasers. These are the different kinds of sachet urethrotom: hook knife, straight knife, or half moon shape. And this is the introducer of the knife. There's another device, electrosurgical device. This is a monopolar or bipolar. There is a physics in this that there is a two electrodes in on the tip of this electrosurgical device, and whenever there is when the current passes from negative to positive pole or from one electrode to another electrode, the biofilm or saline here, it vaporizes and changes into the fourth form of matter, plasma, which is produced locally, not causing to cause the disintegration effect away from the stricture side.
Okay, Noman. What is the difference between dilatation and DVIU? कौन बताएगा? DVIU में क्या होता है और dilatation में? हाँ, विकल्प बहुत अच्छा।
Sir, in dilatation, we place the guide wire and we do the serial dilatation of the
What happens in dilatation? And it will stretch the urethra.
stage the urethra.
Okay. और फिर DVIU में क्या होता है?
In DVIU, we directly cut the stricture portion on direct vision with the help of cold knife or with the laser. So it will heal after with the epithelialization later.
Yes, so there will be a re-epithelialization where we give the incision. So that's why there may be a less chance of recurrence in comparison to the dilatation. ठीक है, लेकिन इसमें भी recurrence होती है. तो DVIU जब भी आप करेंगे किसी का भी, तो फिर क्या होगा कि आपने उसको जो है कुछ ना कुछ auxiliary procedure बताने हैं जिसमें जो है वो उसको recurrence prevent करे. ठीक है, तो अगला ये होगा कि how will you prevent the auxiliary, how will you prevent the recurrence of the stricture after DVIU? तो कौन-कौन सी चीजें हो सकती हैं जिसमें आप कर सकते हैं?
एक तो हम पेशेंट को पोस्ट ऑपरेटिव CISC में रखें, डायलिटेशन।
हम क्या करते हैं भाई? आप लोग भी बोले नहीं, नए वाले बोले, सारे पुराने ही मूर्ख बोलेंगे। और फिर आगा खान का एक्सपीरियंस मूर्ख बोलना है क्या? तूने ओपीडी नहीं की? की है ना? तरीक तो बहुत सब बोले, ठीक है।
Sir, after DVIU, we will keep the patient on the regular CIC and or regular dilatation.
So we'll do better. We'll do with the dialytic catheter, CIC with the dialytic catheter in intermittent self-pressure. After DVIU, we have to do the CIS with dilated or metallic bougie. Okay. अच्छा, फिर आप लोग क्या करते थे भाई? खान करते थे?
Sir, यही same experience. We have also same experience, but we prefer in first stricture patient present with first strap, we go with DVIU, not with dilatation, as mentioned in literature also. Dilatation is only for post prostatectomy stricture or stricture in the sphincter area. So other stricture we prefer the DVIU, and after that we place on self catheterization.
So we should avoid dilatation.
Should avoid dilatation.
Okay, dilatation नहीं करनी चाहिए, ठीक है। लेकिन अगर आपके जो है if the procedure is failed, urethroplasty is failed, or you don't have any option, there are 4 times urethroplasty is failed, then what you will do? You have to do you have to keep the patient on dilatation. तो अगर आपके ये circumstances है तो आप dilatation करें, वरना आपको DVIU करना। And DVIU is only possible in कौन सी urethra? Bulbar urethra. So why we'll do the DVIU in bulbar urethra? अगला क्वेश्चन ही आएगा ना? पर एग्जाम वाले तो कोई आता ही नहीं है, फर्जी नहीं अभी नहीं, विकल्प है ना। तो बल्बर यूरेथ्रा मैंने तुम्हें बताया तो था। तो बल्बर यूरेथ्रा कहाँ होता है? बल्बर यूरेथ्रा के सराउंडिंग में क्या होता है? अब भाई पेनाइल और बल्बर यूरेथ्रा के सराउंडिंग में क्या होता है? कॉर्पस स्पॉन्जियोसम, ठीक है, तो मैंने तुम्हें क्या बताया था?
Sir, in the upper portion, it is thinned out in the 12 o'clock position, so we'll get the full thickness.
So what is the difference of position of the urethra in the penile and bulbar urethra in comparison to the corpus spongiosum? क्या फर्क होता है जो है यूरेथ्रा की जो है वो कॉर्पस स्पॉन्जियोसम के लोकेशन, यूरेथ्रा की लोकेशन कॉर्पस स्पॉन्जियोसम, पिनाइल यूरेथ्रा की लोकेशन कॉर्पस स्पॉन्जियोसम के सराउंडिंग में पिनाइल यूरेथ्रा में क्या होती है और बल्बर में क्या होती है? कोई फर्क है या नहीं है?
So penile urethra में बिल्कुल सेंटर में होता है.
यस, तो पिनाइल यूरेथ्रा इज प्रेजेंट इन द सेंटर ऑफ द कॉर्पस स्पॉन्ज, ठीक है, बट बल्बर यूरेथ्रा इज
तो
eccentric, वो अपर साइड पे होता है, ठीक है, तो वो सेंटर में नहीं होता, ठीक है, सही समझ आ रहा है? नहीं कोई डायग्राम है इसमें?
नहीं सर, ये
नहीं होगी। तो जो बल्बर यूरेथ्रा होता है इट इज eccentric, इट इज टुवर्ड्स द 12 o'clock पोजीशन, सही है, ये सेंटर में नहीं होता, सेंटर से माइग्रेट करके वो eccentric होता है और वो जो है 12 o'clock पोजीशन पे होता है, ठीक है, और 6 o'clock बहुत ज्यादा, जब बल्बर यूरेथ्रा में 6 o'clock पोजीशन पे बहुत ज्यादा थिक कॉर्पस स्पॉन्जियोसम होता है और 12 o'clock पे जो है बहुत ज्यादा थिन होता है, ठीक है, तो इस वजह से हम क्या करते हैं, इस वजह से इंसिजन कहाँ देना होता है? 12 o'clock पे, तो 12 o'clock पे समझ आ रही है नहीं आ रही? ठीक है, तो बल्बर यूरेथ्रा इज eccentric in comparison to the corpus spongiosum, but penile urethra is present in the center of the corpus spongiosum. सही है क्या? नहीं, निदा को नहीं समझ आ गया? पूछो भाई, अगर नहीं समझ आ रहा ना, मुझे नहीं आएगा, मैं मना कर दूंगा, मुझे नहीं आता।
देन पार्ट की साइड पर इंसर्शन क्यों दे रहे हैं, मतलब ये नहीं समझ में आ रहा.
बता रहा हूँ तो इस वजह से कि corpus spongiosum is thinnest and we have to do the complete incision, full thickness incision. तो full thickness incision जो बहुत ज्यादा मोटा होगा तो फिर आप नहीं दे सकते। देखिए भाई, ये है, ये this is penile urethra, ठीक है, तो the penile urethra is in the center, ये corpus spongiosum है, जैसे सबको नजर आ रहा है ना आपको, ये corpus spongiosum है, हाँ, अब नजर आता है, इससे नजर नहीं आएगा, ठीक है, ये जो है ना, this is penile urethra, ठीक है, and it is surrounded by corpus spongiosum, this is cut section, so the penile urethra is present in the center of the corpus spongiosum, ठीक है, तो उससे क्या होता है कि अब देखिए आप इसमें फुल थिकनेस इंसिजन लगाने के लिए आपको कितना बड़ा इंसिजन देना पड़ेगा 12 o'clock में, तो यूजुअली वी डोंट डू द DVIU in penile urethra, ठीक है, because we can't give the full thickness incision in penile urethra, that's why we choose, अगर कोई कहता है तो उसकी अपनी यूरोलॉजी, ठीक है। अच्छा, उसके बाद फिर जो है वो अब यहाँ पे देखें, this is corpus spongiosum and the bulbar urethra is eccentric, ठीक, सेंटर से दूर हो गया है, ठीक है, तो अब कितना आसान है, यहाँ पे कितना थिक है, एट 6 o'clock पोजीशन द कॉर्पस स्पॉन्जियोसम इज वेरी थिक, और जो है वो 12 o'clock पोजीशन पे जो है कितना थिनेस्ट है ना, तो दैट्स व्हाई वी हैव टू गिव द इंसिजन एट 12 o'clock, इसी वजह से DVIU में हम 12 o'clock 6 o'clock को ही देता है तो उसके फीवर, ठीक है।
The different type of lasers we can use for the incision of the stricture, like argon laser, ND-YAG, Holmium-YAG laser, or KTP lasers. DVIUD is a classical technique described by Sachez in 1974. The incision is performed at a 12 o'clock position. The variants in which the incisions are performed at 12 and 6.
अच्छा, ये इन्होंने लिखा हुआ है लेकिन कोई देता नहीं है, ठीक है, प्रैक्टिकली वी हैव टू गिव द, अब आप खुद को भी पता है कि अगर आप 12 o'clock पे देंगे तो क्या होगा, फुल थिकनेस दे सकेंगे आप? नहीं दे सकेंगे ना, और इतना भी फुल थिकनेस नहीं देना है कि ब्लीडिंग हो जाए, ठीक है, तो वी शुड नॉट पंक्चर द कॉर्पस कैवर्नोसम, वी हैव टू गिव द इंसिजन इन द यूरेथ्रा and corpus spongiosum. ठीक है,
I
हमने
would
लास्ट टाइम एक डेफिनेशन पढ़ी थी स्ट्रिक्चर की ना, तो अब इस इंसिजन हम कॉर्पस स्पॉन्जियोसम में क्यों दे रहे हैं? स्ट्रिक्चर तो जो है यूरेथ्रा में। फाइब्रोसिस होती है ना कॉर्पस स्पॉन्जियोसम की, तो इस वजह से हमें जो है कॉर्पस स्पॉन्जियोसम को भी इंसिजन देना है। सही है,
I would like to add on Dr. Tanzil point. It is not contraindicated to give in CN at 6 o'clock position, but there is more chance of bleeding because corpus spongiosum is one of the highly vascular organ in the penile in the penis. So if you do in CN or do DVIU at 6 o'clock position, there is more chance of bleeding, and you have to give more in CN to go through the corpus spongiosum. So it is better to go at 12 o'clock position where there is minimal, you can say, thickness of the corpus spongiosum. 6 o'clock is not contraindicated, but preferable it's 12 o'clock position because there is less chance of bleeding in that, but there is more chance of fistula as well because the corpus spongiosum is quite thin at 12 o'clock position. If you go vigorous in CN at 12 o'clock position, you can go into corpus cavernosa as well. So that patient may have a fistula between corpus spongiosum, urethra, and corpus cavernosum, causing the erectile dysfunction. So it seems to be quite simple and easy looking procedure, and we don't bother while doing it, but there's a science behind it.
अच्छा भाई, इसमें when you are passing the guide wire, suppose the guide wire is not going, what you will do? चलो जो बता देगा, अगर गाइड वायर नहीं जा रही तो फिर क्या करेंगे? DVI की है। नहीं करोगे ना भाई, प्रोसीजर अपन कर देंगे, तो विल नॉट डू द DVIU if the guide, सुप्रवीक पढ़ा हुआ है ना, तो will not do the DVIU if the guide wire not going in, so will not do the DVIU, will postpone the procedure and will do the urethroplasty. सही है, ठीक है, चलो।
The mechanism of DVIU, it aims to separate the scarred epithelium so that the healing occurs by the secondary intention. Epithelialization progress from the wound edges, and wound contraction closes the wound defect and limit the size of area that requires the epithelialization, hastening the healing of the surface defect. If epithelialization progresses completely before wound contractions, significantly narrows the lumen. The internal urethrotomy may be a success. If wound contraction significantly narrows the lumen before the completion of epithelialization, the stricture has recurred. Okay. There are the stricture in penile, bulbar, and pinoscrotal junction. The success rate is 42% in the bulbar urethra and 16% the penile and at 11% the pinoscrotal junction. The stricture length, if the stricture less than 1 centimeter in the bulbar urethra, the success rate is 71%, and is more than 1 centimeter in the penile and pinoscrotal junction, the success rate is about 18%. If the diameter of urethra is more than 15 FR, the success rate is 69% in the literature, and less than 15 FR, the 34%. And if there are a single stricture, the success rate is about 50%. If there are multiple strictures, the success rate will be near 16%. And the stricture free rate is 47% if there's a primary procedure. If the repetition or second DVIU procedure, it is about the 6% success rate.
Up to 1.5 centimeter we can do if there was procedure was not done before, so we can do once. If the recurrence occur after the procedure, तो फिर क्या करेंगे? दोबारा DVIU करेंगे? क्यों नहीं करेंगे दोबारा? ठीक है, एक दफा आपने DVIU किया, सपोज पेशेंट आ गया, UFM कराया, उसका लेस देन 8 है, तो दोबारा नहीं करना चाहिए। क्यों? सब यही कहते हैं ना, नहीं करना चाहिए, तो क्यों नहीं करना चाहिए? Success is very low, even in 1 centimeter stricture, less than 20%. So that's why we should not do the second DVIU. We have to do the once DVIU, and then we have to start the auxiliary procedure. ये जरूर कराना है। CIC भूल जाते हैं, कोई रेजिडेंट भूल जाता है, कोई भेज देता है, कोई क्या कर देता है, तो we have to do the CIC, otherwise the patient will recur the stricture, and after six months or 1 year, and then he will come back to our OPD. हाँ जी 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 जी
when they're planning for information as well as diabetes. Uh, Guidance suggest that if 60 then 60 FR is diabetes, then we can go for conservative treatment that it will suggestion. And second thing is DVIU is one of the contraindication is the penile part of the urethra, but it's written that 16% is success rate is the penile. Usually we do in bulbar urethra. So
So in penile urethra, we should not do the DVIU. Why? Because the corpus spongiosum is very thick, and there will be a more chances of bleeding, and the success rate is very low. ठीक है, देख लें आप कितना सक्सेस रेट है. तो जो है वो वी शुड नॉट डू द DVIU. We should do either urethroplasty, BMG or penile flap procedures, but we should not do the DVIU in penile urethra. अगर कोई एक्सट्रीम कोई ये पेशेंट कहता है कि नहीं मुझे DVIU ही कराना है, तो फिर आप उसमें अटेम्प्ट कर सकते हैं, वरना तो फिर जो है यूजुअली वी शुड नॉट डू DVIU in penile urethra. ठीक है. सेकंड क्वेश्चन क्या था मुझे समझ, तो डायमीटर का क्या? अच्छा हाँ, तो if we cannot pass the 16 FR catheter, तो it means there is a narrowing in the urethra. So 16 FR चला गया तो less likely there is less likely. लेकिन कभी कभी हम मंजूर साहब कहते थे कि जो है वो आप 20 या 24 FR का कैथेटर डालें, अगर वो ना चाहे तो फिर जो है वो तो फिर यूरेथ्रा उनकी जो है यही सेइंग्स है. और जब भी हम पोस्टीरियर यूरेथ्रोप्लास्टी करते हैं तो उसमें हम बड़ा कैथेटर डालते हैं, क्योंकि जो प्रॉक्सिमल फ्रैगमेंट होता है उसमें हम जो है बड़ा कैथेटर डालते हैं टू जज वेदर स्ट्रिक्चर्स प्रेजेंट और नॉट. तो इन्होंने 16 FR लिखा हुआ है, लेकिन मेरी अपनी जो है कभी कभी 16 FR का नेलेटिन भी चला जाता है, लेकिन 20 का नहीं. 20 तक जो है वो अगर आप ना जाए, प्रैक्टिकल ये है, लेकिन ये नहीं है, प्रैक्टिकल बात है कि अगर 20 तक ना जाए तो फिर आप जो है उसको समझे. इसी तरह फीमेल में भी हमने पढ़ा था, कुछ पढ़ा था ना कि फीमेल स्ट्रक्चर क्या होता है, कि 16 FR का फॉलिक कैथेटर ना जाए तो फिर जो है उसमें आप कहें कि जो है उसको स्ट्रक्चर है. Less than 5 centimeter, less than 2 centimeters is very long. So, and the success rate, you can see that success rate is in more than 1 centimeter. So that's why we should not do the DVIU one. I think we should omit the DVIU, in my opinion, because DVIU is not a good procedure. लेकिन आपने एग्जाम में बताना है, ऐसा नहीं है. प्रैक्टिकली जो है DVIU will recur after 1 year, 2 year, 3 year, 4 year, or 6 years. It will recur. So we have to opt for that procedure, which will completely treat the patient.
Hello.
But sir, the purpose of advising CIC in the patients after DVIU is to prevent the recurrence. So maybe it's because patients are not compliant and not because the procedure itself is not a very good procedure.
Patient, if you taught, if you taught the patient about the DVIU, to teach the patient about the CISC, then patient comply you and he will do. But after 6 to 1 year, they do not do that procedure. But you have to keep patient on CIC for prevention of the recurrence. If the patient stops CISC, then it will definitely recur. I think we should continue for lifetime. Okay, in my opinion. Okay.
I would like to add few points on it, Dr. Aslan. While in the normal, while we are not micturating, urethra is collapsed. If there is no urethral stricture while micturating, urethra dilates up to 30 French. So if there is no stricture, 28 to 30 French is the ideal diameter of stricture. And the 16 French is the minimal acceptable range. If it's below 16 French, there is more likely to be symptomatic. There can be urethral stricture, but there will be minimal symptoms. For bothersome symptoms, the FR should be less than 16. And regarding these DVIU and urethral dilatation and open surgery, the success rate of DVIU is around 70% for the first time. And for second time, it's around 33%. While if we consider the success rate of open urethroplasty, end to end, it's above 95%. For buccal mucosal graft urethroplasty, it is above 80%. So preferably open urethroplasty has much greater success as compared to endoscopic procedure. But we just not see these numbers to decide about the patient treatment option. Suppose if the patient is young, he has short urethral stricture, and we can do the and manage by endoscopically, although the success rate is come, but the success rate is less. But the good point about this, there's less chance of erectile dysfunction, and the male patients and the young patients, they are relatively quite concerned about the erectile dysfunction and other uh, complications that are associated with the open surgery, like urine dribbling, erectile dysfunction, numbness in the base of penoscrotal junction. So there are some other bones related to the open urethroplasty. But considering the success rate, what the book or we used to define 80%, 90%, is just the patient is able to pass urine per urethra. But this is not the success in two terms.
We used to perform bulbous urethral strictures. So do we have data about erectile dysfunction after urethroplasties at this part of the urethra?
So erectile dysfunction after DVIU or
Now, after urethroplasty at this site where you are performing DVIU at bulbar urethral strictures, not for
yes.
membranous and penile urethra. So, is there any data for erectile dysfunction for urethroplasty at this part of the urethra?
Yes, sir. Erectile
So
dysfunction.
because I am asking question because this lifelong CIC, because you have an alternate procedure. If you perform DVIU once and it fails, then urethroplasty maybe. But as Dr. Tanzil said, it is the lifelong CIC. So if there is alternate treatment available where patient can get relief lifelong after urethroplasty and worries the erectile dysfunction. So I am asking, is there any data for erectile dysfunction at this part of the urethra after urethroplasty?
So two points to be noted. One, that Dr. Tanzil, I think he stepped he moved one step ahead. It's not like lifelong patient has to do DVIU. It's there's nothing mentioned in literature
CIC,
like lifelong CIC. It has not been mentioned anywhere. Like life patient has to follow it because it's not an easy job to do CIC per urethra. Then the other thing that you are saying, right, regarding the data of erectile dysfunction in patient in which we do DVIU or open urethroplasty in bulbar urethra. Erectile dysfunction is a documented complication of open surgery. That is why recently non-transecting on or the bulbar artery sparing urethroplasty has been introduced. Although there is less chance when we do bulbar end-to-end urethroplasty because it has a dual blood supply, bulbar artery is compromised, but still there is dorsal penile artery that is supplying it. But why still to compromise the bulbar artery when you have a good technique that can spare your artery and have a good dual blood supply? So that is why the newer techniques, non-transecting type of urethroplasty has been introduced.
In literature, it is mentioned that we have to do the CIC for 1 year. But we have seen in our OPD that when the patient stops after 1 year, then there will be after 3 months, he will come with the recurrence. So we prefer that patient will do the CIC whole life if it is compatible. But if there is a recurrence on CIC, then we have to do the urethroplasty. And I think that in near future, DVIU will be obsolete. It will be replaced by the non-transecting urethroplasty. So we will discuss in coming slides non-transecting urethroplasty. So it will be replaced by non-transecting urethroplasty, whether it is augmented with BMG or non-augmented and non-transecting urethroplasty. The results are better than the DVIU.
We have 4 minutes only. 4 minutes रहेंगे. We will complete DVIU. Next lecture में वो बाकी चीजें सारी कंठी कर दी. अच्छा, what are the attempts to improve the outcome of DVIU? Long-term continuous CIC, intermittent self or office catheterization, frequential urethral dilatation or some pharmacological management, colchicine or mitomycin, these are anti proliferative medicines which can be injected during the DVIU inside, just beneath the urethra to prevent the further progression of the fibrosis. What are the contraindication? The stricture, long stricture more than 4 centimeter, complete
फार्माकोथेरेपी भी थोड़ा
colchicine and mitomycin,
माइटोमैसिन सी
mitomycin C,
अच्छा
ये जो हम सर BCG वगैरह में भी यूज
ना वो
करते
तो हम वहाँ का यूज करते हैं मगर इसमें
हैं. Roll
पिक्चर्स में
सर देयर आर स्टडीज.
Optilium भी आया ना, एक नया डिवाइस है. Optilium will dilate the urethra and inject the mitomycin C, which is anti-fibroblast and anti-collagen activity. Will we break the collagen, and then there may be a less chance of a stricture formation after Optilium therapy. They have 3 years they have 3 years data on it, and robust 1, robust 2, and robust 3 studies are there, and they said that 100% recurrence free patients are there. So we have to wait for long term results of that study.
Long stricture, complete stricture, and stricture with dense fibrosis, or 2 previous failed DVIUs, recurrent strictures that occur less than 3 months after first DVIU, or during DVIU there is a complication or the complicated strictures associated with UTI or urethral-cutaneous or ureterorectal fistula, or patient is having the coagulation disorders. And these we have already been discussed. The best outcome is about 50 to 70% for well-selected patient. Recent at less than 3 month stricture-free rate is 0% after 2 years for the second attempt. Recurrence at 6 months stricture-free rate is 40% after 2 years of second attempt. Or repeated DVO patient and undergoing the third procedure is called repeated DVO dilatation. The complication of internal urethrotomy is the recurrence of stricture, urethral hemorrhage, clot, erectile dysfunction, UTI, and fistula.
But erectile dysfunction is less common. We will not transect the bulbar urethral artery. So erectile dysfunction is less common after DVI. It is less than 1%, I think.
It can happen in those cases when the fistula has been created.
Yes.
अच्छा एक हमें आप जरूर sometimes you should show us a video where DVIU up to which level should we cut or incise or use laser, because this is also debatable. हम भी जब करते थे, अब तो हम नहीं करते, तो then हमें भी लगता था कहाँ तक जाएं. ठीक है, sometimes there is worry of bleeding, sometimes there is worry of perforation. So what is the optimum level to incise or use laser maybe?
Sir,
ये भी एक वीडियो आप जरूर हमें एक दिन दिखाएं so that
ये हम फिर परफॉर्म करके फिर हम ये वीडियो और ये इंशाल्लाह जो यूरोप्लास्टी.
ठीक है. Thank you.